In my end of the world to everybody, and good morning to some of you. And I'm really happy to be here and to be able to talk about our work. I would also shortly like to introduce Darius Rohani, who's also with me here. He used to be my PhD student that I did most of this work together with. And in the end, I think there's going to be plenty of room for questions. And if there's some super detailed questions, I'm happy that Darius is here to help me answer some of the detailed questions. I think, Andrea, in terms of questions, I don't know if you want to say something about how that works.
Sure. So please feel free to put in the Q&A questions that you have, and then we'll save time at the end to answer them. And yep, that'll be great. Thank you.
Yeah, thanks. So, I do already introduce myself, but just a few words on myself. I basically consider myself as a computer scientist, but I do a lot of my work in the health space, and I've been especially working with mental health over the last 10 years. But we also do some projects here in Copenhagen with, for instance, cardiovascular diseases and diabetes. But as you can see at the bottom here, my research interests are sort of mainly these computer science types of research areas. So this is ubiquitous computing or pervasive computing, pervasive healthcare, of course, human-computer interaction, and then sort of generally software architecture. I do have a website. You can see it over there at the right, and I actually try to put many of these things out there. And actually, the talk today that I'm giving, I actually wrote this up more or less as a sort of a small text, which is available on my website. So there's plenty of resources there to go and have a look afterwards. I don't think it's necessary to sort of go into the details of sort of the global burden of diseases in this context. But what I normally say is when you look at mental health, it's sort of been on the top 25 list of dailies over since 1990, and it sort of keeps growing. So I think every year it sort of moves up a little bit in the list of dailies. And the last update from this year, 2020 updates from the leading causes up until 2019 is now on a 13th place in terms of depressive disorder. Another interesting sort of finding. So last year when this came out, or this year when this came out, so anxiety disorders is now also on the top 25 list of disability adjusted life years. So the whole mental health space is, as you probably all are aware of, is sort of a super important and very interesting sort of disease area to work with. Another thing that sort of is at the backbone of what we've been doing is that back in 2007, this little guy came out. It's actually, when I look at this picture today, I found this old picture. It's actually funny to see how small it was back then, the iPhone, and a couple of years later, the Android phone came out. And back then, that actually led some researchers, including me, but also others, to sort of think about what could we do with these kinds of new computing devices. These smartphones were actually, when we started looking at them and tearing them apart, you suddenly find that these were very, very powerful devices with a lot of computing power, with a lot of sensing power, with a lot of sort of communication power. And to a large degree, they were sort of much more powerful than many of the laptops and so on that was available back then. And most importantly was that these kinds of devices were interactive, and they were always sort of with the persons. They were very, very personal. So you could use these devices as an extremely sort of personal way to actually get access to understand what was going on with people in sort of their everyday life. And if you compare this with the kind of research that was done previously in mental health, this was sort of very clinically oriented. It was sort of pen and paper types of surveys and these kind of things. So a lot of I had to admit, sort of technology guys, at least those were the ones that I knew back then, we were sort of interested in trying to understand what we could do with these things. And I still remember that we were having these discussions in a technology forum, and then I was asking some of my clinical friends, not in mental health, but sort of the general, the doctors that I knew, that who was sort of the main person in affective disorders or bipolar disorder or sort of major depressive disorders in Copenhagen that I should work with if I wanted to investigate these things. And they gave me the name of Lars Kessing, who's a professor in psychiatry here in Copenhagen that I've been now working with since 2010. But I phoned him and said, well, you know, we have a bunch of computer scientists and we have this idea that we can use these mobile phones to actually monitor patients and predict their sort of depressive episodes. And Lars Kessing, he later admitted to me that the first phone call that I made, he actually considered me to be a manic patient. He thought that I was completely crazy and he had no clue of what I was talking about. And since then, we had a very fruitful collaboration once he understood what I was trying to say. So that was the main ideas. So what I wanted to do today is that we recently published a review paper that is looking back at the last 10 years of research in mental health or mobile health technologies for mental health. So I'm just going to go and talk a little bit about what has happened over the last 10 years to try to provide an overview of the technologies, what sort of technical evidence is there, and what sort of clinical evidence is there. And then in the second part, I'm going to talk about the MUBS study, which I did together with Darius, where we were trying to look at how we could support the method of behavioral activation and build it into these types of mobile health technology and build in some recommender technology for behavioral activation. So I'm going to talk a little bit about behavioral activation and this recommender technology, how it actually works, and the design and some studies that we've been doing. And then in the end, we have some time for some questions and answers. So that's basically the outline of my talk. So if we take the first part first and sort of look back to what has happened over the last decade, since we went back to 2009 because that was where the Android phone came out, and this was where you sort of could start to investigate these things. And the Android phone were very open and easy to program. So so that's where most of these things actually started. So what we can see what has happened over the last 10 years is definitely that mental health technologies has been gaining a lot of momentum. So quite a lot of technologies has been designed, both in terms of research projects, but also as commercial applications, as you're probably all aware of. A number of clinical researchers are using and evaluating these mental health technologies. There's a wide range of pilot studies. There are several randomized clinical trials, so like big RCTs going on, and they're even now also being published different meta studies on these RCTs. So it's sort of, it's technologies and it's studies and it's evidence that is climbing up the evidence ladder, so to speak. So there is a growing body of knowledge about these things. And also the governmental and sort of regulatory bodies, they're also picking up on this. So definitely in the US, the National Institute of Mental Health is picking up on these things. As you are probably aware of, when I talk to my British colleagues, the National Health Services in the UK is picking up on this very seriously. And in our local country in Denmark, the Danish Health Authorities is also looking very seriously into this space and trying to do some more regulatory initiatives in it. So this is your homepage. You know it better than I do, but this is just the homepage of the National Institute of Mental Health. I have a whole section dedicated to mental health apps, as they call it, and sort of have a discussion on how this could be the technology of the future mental health treatment. Back when we did the survey, so this was early last year, we did this, so that's approximately like a year, like 12 months ago now. There was 227 studies registered, at clinicaltrials.gov, which is within this space, which is sort of mental health apps space. So yesterday when I was preparing this talk, I made the same search. Today it's 413 studies running in this space. So different kinds of registers. These are registered studies in clinicaltrials.gov in this space. So you can definitely see that there's a lot of activity going on in this space. So what we did was that we tried to do this review. So a lot of reviews normally, especially in sort of the clinical sciences, look at studies. So you would normally see, you would ask yourself, you know, what kind of evidence exists for the efficacy of reducing depressive symptoms using maybe some sort of a mobile phone app or something. So that you would look for the sort of an outcome measure, a clinical outcome measure, and see what does the different studies actually show in terms of sort of outcome measures. But since we're computer scientists and sort of also interested in the underlying technologies, we thought it could be interesting to actually do a review of the different kinds of technologies and what were the different features and characteristics of these technologies. So instead of looking at studies, we did a review of different technologies. So we looked at only research technologies. So this is technologies that was being published in peer-reviewed literature in the last decade, so 2009 to 2019, within the Ubiquitous space. So this is mobile and wearable technologies, and we sort of categorized it within severe mental health illness as defined by ICD-10. And it resulted in 45 different kinds of systems, and we divided them into two major groups. So we had a clinical and non-clinical, where the majority of the system were actually designed and used in a clinical setting, which was actually very positively surprising for us. And then in the end, we did some typology to sort of characterize what these technologies were like. Here's a list of all the different technologies. We were actually very positively surprised that there were so many. It was super interesting to actually get this overview. And so here's the list of the different, the top part is the clinical oriented ones and the lower part are the non-clinical ones. So when we say non-clinical, it's because they sort of address emotional well-being, for instance, or stress or something like that. So that's the definition of a non-clinical focus. And of course, I can't go into all of these details, but this list and all the references are also available on my website if you want to dig deeper into this. There are probably some of them you recognize, but I also was very surprised that there was a lot of studies that or systems that I've never seen before. So that was interesting. If we look at some of the characteristics of these, here we sort of did a categorization in terms of what severe mental illness disease they were addressing according to ICD-10. So these are sort of organic substance misuse, schizophrenia, mood disorders, neurological disorders, behavioral disorders, and so on and so forth. And what you actually see is that the majority of all of these systems, I don't know if you can see my cursor, but the majority of these systems were actually addressing, so almost 60% of these systems were addressing mood disorders. And I actually think that this is still the case. So mood disorders, affective disorders like depression and bipolar disorder is by far the most sort of busy space in mental health. So if there's some young researchers out there that want to make a contribution in this space, you might want to look some other places where it's less crowded. So that's one finding. The other finding when we were sort of looking into the technology components, and we divided it into sort of technology component for sensing a technology component for some clinical assessments. So this is typically surveys, questionnaires, kind of things, predictive modeling, intervention, and then some user interface sort of design issues. Again, you see that 84% of all the different systems were focusing on sensing. So again, you have, so if you put these two pictures together, the majority of the technologies in sort of mental health has been focusing on sensing for mood disorders. That's sort of one takeaway message from this picture. And not a lot has been looking at sort of trying to provide some intervention. So what can you actually do in terms of intervention? So that was another finding. And here's just sort of a historical overview of the number of systems in terms of publication year. And you can see there's sort of an initial early wave, sort of an enthusiastic wave of initial systems, 2010, 11, and 12. Then it seems like people were going back in the garage, back in the labs, were building sort of a next set of system, and then we saw a new wave with a peak until now in 2016, which seems to be a good year in terms of technologies for mental health. So this was some of the things we found in this survey of the technical system. We also did, this was together with Darius, we also did a survey more specifically on the sensing and mood symptoms. As I said before, this was the main space. This was where the majority of the publication has been done, is sort of in the intersection between sensing for mood disorders. So we wanted to investigate in further details. So what have all these studies then found? What is it we have to sense? What kinds of features, so to say, or aspects do we want to sense in order to make good systems for mental health and in particular mood symptoms? And we had to narrow it even more down and only look at depression. So we actually looked mainly at depressive symptoms and say, you know, what are the relationship between what we actually sense and depressive symptoms. So again, we did a systematic review and trying to find all the papers that has been dealing with sensing, mobile sensing and mood disorders. We screened nearly 1,000 full papers, and we included 46 papers. And again, we divided the studies into clinical and non-clinical. And by clinical here, we mean that the individual participants in the studies were actually diagnosed by a clinical doctor, a psychiatrist. So they had a clinical diagnosis. And the other ones were labeled as healthy individuals because they did not have a diagnosis. So again, here's the list of the different studies. You might also recognize some of these. But again, here's the list of the 45 different studies, and it's divided into two tables. So this is the table with the non-clinical samples. So we had 20 of those studies. And then there's the table with the clinical samples, and we had 26 of those where there were clinically diagnosed people involved in these studies. And then we took the different features, the sensing features, and put them into these major categories of features. So there's a bunch of features that was related to physical activity. So this could be step count, this could be movement, distance traveled, and activity in terms of activity recognition, whether you were walking or running and so on. So and physical activity was by far the major category. So 48 of all the different studies were having some sort of sensing of physical activity. The second was location and social. So location is a pretty obvious feature to collect with the GPSs that are built into all of the phones by now. Social activity were things like phone calls, texting, social media, and so on. So this was 38 of the studies, including this. And then we see the other categories like device information, so screen on and off, for instance, is an example of a feature in the device category. Subject is more personal, subjective features. And then there was biological, and actually you can see biological sort of things like heart rate or blood glucose level or something like that. Actually, very few studies were addressing these things. And then finally, environmental, there was only 2 studies. So this could be weather or air quality and these things. Only 2 studies were addressing this. The green part of these pie charts is what part of the studies found significant features in this space. So go back to physical activity. So 46% of these 48 studies were found that there was a significant correlation between this particular physical activity feature and depression. So you can see that physical activity, that's 46%, and location is 50%, many of these have significant correlations, whereas the social ones, which is actually very interesting, only 1/3 of these has a significant correlation with depressive symptoms. So we also did this plot. It's a little bit complicated plot, so I'm not going to spend too much time on explaining this plot. If you're interested, there's a lot of details in the paper, but what we were trying to do with this plot was basically trying to illustrate, and in this case, this is for the non-clinical sample, we were trying to illustrate which of the different features had the strongest correlation with depressive symptoms. So if you either are at one end here at 1, then there's a very strong positive correlation. So for instance, in this case, homestay has a very strong correlation with depressive symptoms in a non-clinical sample. Whereas if you're at the opposite end, there's a very strong negative correlation, but still a strong correlation. So here, location, clustering, or distance have a very strong negative correlation with depressive symptoms. So if you is very immobile, you don't move a lot, then there's a strong negative correlation with your depressive mood. So you want to have features that are either in one or the other ends of this, because then you have strong correlations. If you have features that are in the middle, they don't help you much. And here's a similar picture from the clinical samples. So here's some strong correlations in terms of call frequency, call durations, and so on, and some on activity, and so on and so forth. So the whole purpose of this study was to try to come up with, in a systematic way, across all these studies, to see if there was an agreement between the studies of which features actually correlated strongly with different depressive symptoms. And we were trying to do this. And this was sort of as far as we could take it, because there was a lot of inconsistencies in the different studies, the way that they have been collecting this data, what kinds of features they were collecting, and so on and so forth. But these 2 pictures here are sort of the strongest result of this paper, because it basically tells us something about, in the existing studies, which of these features have the strongest either positive or negative correlation with depressive symptoms. So we actually set out this study to sort of with the hope that we once and for all could figure out what was the relationship between different sensing features and depressive symptoms. And we could sort of nail it and say, well, you just have to collect these 5 different types of features, then you're all good. Unfortunately, this turned out not be the case. So there was a lot of howevers to this study, and there was a lot of things that was difficult. So one of the things is that there's no standard data collection and feature extraction methods. So people, not people, but the different studies were very different in very simple things like what step counts, what is a step count, how do you collect physical activity, what is social activity, and so on and so forth. Even things that you think are standard like GPS data was treated very, very differently. So the features were not standardized in any way. So it's very hard to compare across the different features and across the different studies. Then the second thing is that it seems to be that every psychiatrist has his favorite mood assessment tool. We found that there was a wide range of different clinical and non-clinical mood rating scales were used. In total, there was 20 different mood. So we're talking about 46 studies, and in 46 studies, there was 20 different rating scales used. So that's, again, makes it very, very hard to look at depressive symptoms across different studies. And then finally, in terms of statistics, sort of this, we were talking about statistical correlation between features and depressive symptoms, but correlation also turns out to be many different things. And we found more than 11 different methods of actually calculating these correlations. So it turned out that it was very difficult to make. We came a long way, and we have a good understanding of these things, but there's still a long way to sort of nail down exactly what features to collect and how to assess the clinical mood and sort of make the correlations between the two. So I guess that's the main message from that study. I also just shortly wanted to bring up this study. This is not something that we've done, but it's just to illustrate that there are some meta-reviews on the efficacy of these things out there. This is the paper by John Torres and friends, where they looked at 18 different RCTs using 22 different apps for sort of up to 24 weeks of intervention. And they also found that they were using quite a lot of different depression scales. So here's the list of the different studies and whether they found an effect in terms of improvement in depressive symptoms across all the studies here, and that sort of makes them conclude that the evidence to date indicate that mental health interventions delivered by smartphones can reduce depressive symptoms. So that's the overall sort of RCT conclusion or meta-review of these RCTs. But they sort of continue that it's very difficult to establish the single most effective components of smartphone interventions or to determine which population these interventions are best suited for. So this is sort of the meta-review of these different RCTs. So that sort of leads me to the second part of the talk, where we wanted to talk a little bit about what we've been trying to do in terms of intervention. So here we have this meta-review saying that it's hard to figure out what kind of intervention is the most useful one. And we also had the other meta-review that was sort of showing that not a lot of these studies were actually looking at trying to do intervention technology. Most of them were sort of focusing mainly on sensing technology. So we tried to make an intervention technology. We call this MUBS. Actually don't know exactly why we called it MUBS. Maybe Darius can answer this later. But it takes its outset in this behavioral activation therapeutic approach. It was this project was part of a larger research project called RADNIS. There's a description of this project also on my website if you were interested in this. But this had sort of three overall goals of first to design mHealth technologies for monitoring and treating mood disorders, which is what I'm going to talk about today. But there was also some other student working on sort of large-scale mood prediction based on sort of large-scale studies that we have done here in Copenhagen. And then finally, we were trying to establish clinical evidence for the ability to reduce readmission of these patients. So a slightly different outcome measure than you normally see in these clinical trials. But just talking about the first part today, we took as an outset behavioral activation. So looking at this up in the textbook and on Wikipedia, they say it's sort of third generation behavior therapy for treatment of depression. It's from sort of the 90s. I think the main reference is the Jakobsen one that I listed below, that sort of started this. It's mainly sort of growing out of CBT, but focusing on the behavioral component of it. And it has sort of repeatedly been found to have the same effect as full CBT for the treatment of depressive symptoms, but it's just much more simple, and it can be administered by sort of nurses and don't require sort of full trained psychiatrist or psychologist. The main method is captured in this acronym called ACTION, which is basically that you have to assess the behavior or the mood. You choose alternative responses, you try out those alternative responses, you integrate these alternatives, you observe the results, and now you evaluate. It sounds sort of pretty straightforward. So it's a sort of a trial and error loop in some sense. But of course, there's a theory and a very detailed method behind this. I think they are guided by a set of principles, and I think the principle number 9 pretty much sort of encapsulate the whole philosophy of this approach, where they say, and this is their quote, "Don't just talk, do something!" exclamation mark. So the whole idea is to sort of not just sitting and talking about all the problems, but actually try to do something about it, and that's why it's called activations. You wanna activate the patient. A core component of this method is that you ask patients to do very detailed daily and hourly diaries. So here's an example that I've taken from one of the patients that we were working with. It's in Danish, so you won't understand anything, but it sort of illustrates how the patient is very detailed on an hourly basis, trying to make a diary of what he or she is doing. And then he or she puts a figure in terms of pleasure next to each of the hours. So how were you feeling in that particular time slot? So what we initially did was that we collected a lot of these paper-based behavioral activation schemas from 9 different patients, and in total a recording of 2,000, almost 500 hours of recording, manual recording on paper-based diaries like this. And we were trying to figure out, and nobody seems to have been doing this before, we were trying to do this data analysis and trying to figure out, what are the kinds of relationship between different types of activities and then the pleasure scores. And we found, so this is the distribution, we found that movement related activities like going for a walk or taking the dog for a walk or something like that, or were actually the types of activities that generated the highest pleasure score. And the second highest one was the social one, second to the right, which was the second high one. So if you're doing different kinds of social activities like having a cup of coffee with a friend or calling somebody for a talk. So this was sort of a very interesting way of actually looking into the many different types of activities and the relationship to the pleasure score. Another thing we did was to try to look out for how long time would you actually do this, because if you're sitting drinking coffee all day, it might be good in the beginning, but at some point either your stomach will start hurt or you will get bored. So we were trying to do this second order analysis, and we did this for all of them, and this is the one for social activities as far as I recall, that you can see after 2 hours of social activity on a day, it doesn't give you any pleasure anymore. So up until 2 hours of social activity per day seems to be the optimal way of doing this. So we did this kind of analysis in order to try to understand, behavioral activation and some real world data. And then we moved on into sort of a user-centered design, as we always do here in Scandinavia, where we invited everybody to have these co-creation workshops and design sessions and so on, where we did a lot of lengthy sketching, brainstorming, discussion about how we could actually turn this into a technology for behavioral activation. And we came, so I'll cut this very short, but we basically came up with a set of design principles for the system. So first and foremost, it should support this activity tracking and registration, just like we just saw in the behavioral activation schema, paper-based schema. But instead of doing it every hour, we should do it sort of morning, afternoon, and evening instead. And instead of having sort of detailed putting numbers to each of the different hours in terms of mastery and pleasure, which is actually the textbook version of behavioral activation, we came up with this thumbs up and thumbs down rating instead. It's much more simple. The other thing is that it should support activity planning. So you want to be able to plan good activities. And this is also textbook behavioral activation, but instead of having sort of a detailed calendar, time slot calendar, like the one we just saw, we just want to have sort of more loosely list of good activities we want to do, and then try to understand what activities were actually good and beneficial. Then the app should be inspiring, and this is also basically back to the core component of behavioral activation, because in behavioral activation, the patient would normally go to the therapist and get inspired to actually do some nice kinds of activities. So the therapist would help the patient to identify and plan and perform some nice and new healthy activities. And of course, the idea is that this MUBS system, the technology, should somehow not replace, but at least assist in similar ways with coming up with inspirations for good activities. And finally, we call this self-efficacy, but it's basically, it should be a self-management tool. So we wanted to engage the patient to have this sort of more as something that can help and plan and track activities in between therapy sessions. So we want to have it sort of to work in between therapy, basically, and more independent of having access to a therapist. So that was sort of the four main design principles. And then we did a feasibility study, because the core thing in this technology was whether we could actually make a recommendation technology for behavioral activation. And we published a paper on this, but basically we asked ourselves, is it actually possible to automatically identify and thereby recommend activities that are healthy for a person? So based on a lot of data that we have been collected, we did some simulation. Training on this, and I won't go into the details here. There's a very nice paper that also Darius is the main author on, that we did some simulation that actually showed that with a ungefähr 70% precision, we could come up with a suggestion for an activity that the user would then deem as good, basically. So without knowing whether the user would rate it as good or not, if we suggested something, then 70% of the cases, it turned out that the user actually deemed this as a good activity. So the core idea of using recommendation technology for behavioral activation seems to be feasible. So we put this into an app, basically. So here's the pictures, and the app is actually available if you go on the Google or iPhone app stores. You can actually download it and start using it. It supports activity tracking and registration. It has here's some pictures on how you do this. Here's a list of activities that it suggests you to do. So it suggested me to review a paper, goddammit. And then once I have completed these activity, I can sort of give it a thumbs up or thumbs down whether I enjoyed it or not. And if I enjoyed it, I can add it to my routine. There's also a small social component down here. It might be very difficult to see, but basically, if this is something that you want to recommend to others, you are also able to do this. Then there's the activity planning part of it. So the system contains a catalog of 380 something enjoyable activities, and this is again a list of activities that we have pulled out of a textbook, or sort of a list from a textbook of activities that has been proven to be enjoyable. So having drinks with friends, for instance, running, and you can see that we have different sources, right? So drinks with friends was actually recommended by other users. So this is a social activity that others have found useful. And then there's this one, like review a paper, which is definitely my own. So this is something that I put in myself. And then there's some here that comes from a standard list. So go to a quiz or trivia tonight. So there's this opportunity for using standard ones. You can create your own, but you can also use activities that has been recommended by others. And then finally, there's these difficulty levels that are highlighted here with these dumbbells. Normally in behavioral activation, you would start, if you're very depressed, you would start doing very simple things, like going for a very, very short walk, spending time in nature. And then later, when things are going better, you move up your difficulty level, and at some point you might go for a run. And then also we added this support for building routines, so you could put in a weekly routine here. And then there's the recommendation part, which is sort of the core technology part of this. So we have this gorilla icon here that is able to recommend you different things. And here it seems like practical activities. I've done my share of practical activities for today, so it doesn't recommend me anything in practical activities, but it seems like I still need to do something in spare time and daily living. Daily living is like, cleaning the kitchen or making up my bed or something like that. I typically need to do stuff in this area. So it recommends me to do things like this. Again, in some of the papers, there's a much more detailed description on how Darius implemented this recommender model. But it's basically sort of a naive-based approach based on a bag of words that takes in different input parameters. The way it works in the user interface is that it basically comes up with 10 activities for recommendation, which is split between 4 prior activities that you have done before, and then it comes up with 6 new activities that you've not done before. So you constantly get inspired with new things. So the whole thing is implemented in Flutter. So Flutter is this cross-platform programming environment for both Android and iOS. So the app is available, and we actually have a lot of users. I don't know if you checked recently, Darius, but there's a lot of users actually using it. We don't know who it is and where they come from. So it's available, and we keep it running. It's built on top of the card mobile sensing framework, which is sort of our open source component, like Purple Robot-ish platform for building these things. And in this particular app, we are using Firebase as the background. And we're currently in the process of implementing version 2 that takes in all the experience we have from the initial studies. And talking about studies, my last slide is basically that I wanted to just say that we have been doing a feasibility study where we looked into having clinical diagnosed people with bipolar or unipolar disorder, using it for 8 weeks. And we have published, so this is the CAI paper from this year, where we published sort of the usability results. So here we were asking, so we had 17 participants using it, and they were planning almost 3,000 different types of activities, and we've done a very detailed analysis of what these activities were and what they used it for. And then we did this unified theory of acceptance and use of technology, kind of evaluation, where we basically ask people their intention of using this, and it has some fairly good scores without going into details. Here's the list of the participants, but that's not what I wanted to highlight. What I wanted to highlight is basically these results, that one of the things we found is that the majority of the users, this is the sum down here, so 32% of the users were still picking activities from the list, and only 4% were actually accepting the recommendation. So even though our recommendation technology works in theory, we've proven that, there's still something, and that's why we're making a version 2 right now. There's something still we can improve on to actually maybe having users pick even more recommendations. But this is a general problem, without going into so much details on this, but this is the same problems you see in Netflix and other recommender systems, that actually the amount of recommendations that are actually picked by users is fairly low. But we did find a lot of activities. A lot of activities were planned, and it was used quite heavily, but not so much for the recommendation part. We are right now just finished a clinical study, so this is unpublished material. We're looking forward to get this published, but basically what we could see in the PHQ-8 scores, and remember this is a single arm, non-randomized in any way, is that we could actually see a significant reduction in PHQ-8 scores, and especially if we look at those that were initially had a high PHQ-8 score, which is sort of moderate to severe depressive people, they of course had a much larger effect than people who started out being mild or not depressive. So by doing this stratification, we can clearly see that there are some effect. And we're hoping and trying to find funding to actually run a real clinical study on this. So that's what I wanted to talk about today. So basically, I've been trying to look back 10 years and then trying to also present a little bit about what we have been up to lately, where we have been trying to sort of switch from sensing to intervention technology. And this is still what we're doing. So down here, you can see something about we're looking into comorbidity as well. This is another interesting thing that we're wanting to look into now. And of course, the whole technology platform is always interesting for technology and computer scientists like us. So, and of course, this is work that I've done with Darius, and he's here, so that's very good. And also Marie Farhold Jebsen, Lars Kessing, and Anna Tuxen, who are the psychiatrists and psychologists at the Copenhagen University Hospital. And that's end of my talk. So if Andrea, I don't know if there's any question that has been popping up along the way.
Yes, there's been two. Thank you so much for a fabulous talk. That was really terrific. We really appreciate it. I'll share the ones that people have posted so far, and if others have questions to come up, this is a lot of food for thought, so thank you. The first question was that the app is fascinating, and for the activities they wondered, and I think actually you then covered it, but I'll just make sure to get it answered. Is there potential for incorporating mindfulness activities? I may have missed this, but is it tailored to the individual, as yours had to review a paper, or are they general across all participants?
So Darius, I think you can actually talk about this because the mindfulness came up, right?
Yeah, we actually went to interview a clinician who's doing mindfulness, and we're still debating how to add this to the app, because these are very they're mostly like very active in the sense of it's quite specific. Okay, take the dishes or go for a walk. While the mindfulness could need some techniques or some more higher order level of understanding what exactly the person should do. So we are having a bit of discussion on that.
Yeah. Yes, exactly. But it's slightly more complicated than just having sort of a line of text like, you know, take the dog for a walk. But in principle, we have been talking about this because in principle or in theory or hypothetically, you could be recommended a mindfulness activity.
Mm-hmm. And to clarify, the activities, they were tailored to the individuals, or are they general across all participants?
That's also for you, Dias.
So the list we had with inspirations, the 384, they were general for all participants. And then, of course, the recommendations were tailored to the individual. Only that person's data.
Yeah. So the catalog of all the activities were general for all, but the way the recommendation technology or the recommender model works is that it's getting trained and then it builds a personal model for each person. So it takes from the set of general activity, it takes the one that seems to be most useful for a specific person.
Thank you. Next question was thinking about when you talked about behavioral activation, the role of disability, where not everyone has capacity to move, and what your thoughts are on how to enhance accessibility in mental health interventions.
That's a very good question. I haven't thought of that. That's a super nice question. I really haven't thought of that. I don't know if the person who's asking this question can elaborate a little bit on it. Is that possible, or I don't know how this works. But,
I don't know that they could jump in, but Alice, feel free to type in more if you'd like. In the meantime, I'll ask a question while we may be waiting. Or did you have more on that point in the mean?
No. It was more sort of clarifying questions. Yeah.
So in your in the results you were showing were of the mean number of those participants who what they were using in the features. I was curious about the fact that 9%, it looked like on average, added it to their routine, and sort of would love your thoughts of, is that something that, you know, how you might build that feature out more and where you see that as being important or not. Yep, this slide, exactly.
Yes. Yeah, it is interesting, and as I said, on a general level, we are trying to take these results into the second generation of the system. I can't remember, Dias, what did we end up with? Because the routine part has been up for discussion many times. Because sometimes we think it's super useful, and sometimes we just think it's making things too complicated.
Yeah, but basically it depends on the person. So in the interviews afterwards, we saw that actually the people in full-time jobs or were had quite a tight schedule, you could say, in some sorts. They preferred the routine. They all really liked the feature, while the ones that were mostly unemployed or they used it less. So it's quite individual in who used it, but for sure we want to keep it.
Yeah, you can also see here that's actually true. So the two first participants who are unemployed, they don't use it, but the ones that have full-time jobs, they use it a lot. Maybe it's one of these, you know, you see in many technologies that there are different features that appeal to different users.
And someone popped in to say, with respect to a routine, did you evaluate in your earlier work whether individuals with depressive symptoms have difficulty sticking to a routine, which we know is the case. And so it's sort of interesting to see how 2.0 might think about that tailoring. Absolutely.
Yeah.
Another question we received is, have you considered making a to-do list options where folks can add the actions they want to do that day or that week and let the recommender system suggest when to do it? I wonder if it would increase uptake on recommendations.
That's a good idea. We should note that down. So that the recommendation is, so just to get it clear, so you pick what type of activities you want to do, and then the recommendation is only about the time. Yeah, that could be. We'll have to rewrite the recommendation algorithm, but it's because right now, well, it's a completely different algorithm actually, because right now there's no timing in the recommendation. Isn't that correct, Darius? It doesn't suggest you when to.
Actually, it has the morning, afternoon, evening in the algorithm. So actually, yeah, we have when is it more probable that you would like a run? Is it in the morning or in the evening? So
okay,
since it is, but not in that as the person asked, we didn't consider that at all, and that's a good note.
So I'm seeing we have 1 minute, so we have more questions coming through, which is of course the best, but I'll just close on this one. So really interesting talk. And do you have thoughts for incorporating the list of activities with the sensing data somehow? So for example, behavioral activation may enhance GPS or physical activity, or perhaps using the sensing data as feedback for the patient.
Yeah, definitely. That was actually our initial idea, but so we haven't quite finished. So now we're only sort of halfway. But the initial idea was actually to take much more of the sensing data into the recommender algorithm. We just haven't gone around to doing that yet. I think that's the right answer, right, Darius?
Yeah, precisely, and that's what we're working on. The second version is including this context information.
Yeah.
Well, thank you. We can't wait to see it.
Yeah.
Well, thank you, Jakob. Thank you, Darius. It is a top hour, so we'll close now. But first, thank you both for coming out. 7 p.m. Copenhagen, taking your evening, and. Next month, we'll have Nathaniel Counts from MHA on the 2nd, from 12 to 1. We hope to see everyone there, and I hope everyone has a healthy and happy 2021. Thank you, everyone.
Yeah, thank you.
Bye.
Thank you.